Okay, so I'd like to welcome everybody and say good evening and welcome you all. If you don't know, I'm Maria Morgan and I'm the president of the British Association for the Study of Community Dentistry, or affectionately known as BASCARD. I'd like to welcome you to this, our first ever masterclass. The aim of our new masterclasses is to offer mentorship and key insight into public health, dentistry and strategic health leadership from past presidents of BASCARD. And I'd like to thank Professor Richard Watt, who was president of our society from 2008 to 2009. Doesn't seem that long ago, Richard. Not only for launching the masterclass series, but also as acting as inspiration for their introduction. So thank you for that. To kick off proceedings, I would like to hand over to Ross Keat, who has organised the sessions, our early stage career council member and specialty registrar in dental public health. Ross, hand over to you.
Thank you very much, Maria. Well, firstly, I just want to say thanks to Ilona for coming as well today. Ilona is a reader in dental education at Cardiff University and an honorary consultant in dental public health. And to echo what you say there as well, Maria, thank you to Professor Richard Watt for agreeing to undertake this inaugural session. Also, Maria, I think that it's really great that we've managed to come together and do this, turn the pipe dream of the masterclass series into a reality, and we've now got 83 attendees at the meeting, so I think that's a fantastic achievement. A little bit of housekeeping. Could I please ask that everybody keeps their cameras and microphones turned off during the presentation to make sure we don't get any feedback? And if you've got any questions, please write them in the chat box. It's going to be the job of myself, Ilona and Maria to collate these and to pose them to Professor Richard Watt as we go forward into the Q&A session at the end. If you want to leave your name with the question as well, that's absolutely fine, and we can share your name as well. So to give it a little bit more of a personal feel. We're going to try and finish the session promptly at 7:30 p.m. and as we've already said, the session is going to be recorded, so we can post it on the BASCARD YouTube channel. There'll also be an evaluation form circulated, so everyone can fill that in and get a CPD certificate for attending this evening. So I just want to say a little bit about Professor Watt. Richard is a professor and honorary consultant in dental public health in the Department of Epidemiology and Public Health at UCL. He's the director of the WHO Collaborating Centre on Oral Health Inequalities and Public Health, and is also director of research for Central North West London NHS Foundation Trust. He graduated from the University of Edinburgh Dental School in 1984 and then completed an MSc and a PhD in dental public health at UCL. His main research interests focus on social and commercial determinants of health inequalities and the development and evaluation of community-based health improvement interventions. He is currently the co-chair of the Lancet Commission on Oral Health and is an NIHR senior investigator. He has published more than 317 publications and secured £50 million in research income from NIHR, MRC, ESRC and NIDCR. In 2014, he received the IADR Distinguished Scientist Award for Behavioural, Epidemiologic and Health Services Research, and in 2020, the IADR Distinguished Scientist Award for Global Oral Health Research. And of course, most importantly, he's a past president of BASCARD. So without any further ado, I'll pass you over to Professor Watt to deliver this presentation entitled From Basement Prosthetics to Oral Health Inequalities, Reflections of a 40-Year Journey.
Lovely. Well, thank you very much, Maria, for your very kind invitation. And thank you, Ross, for that very nice introduction. So good evening, everybody. It does seem quite weird because I'm sitting here in my slippers in my upstairs study, and I can see lots and lots and lots of very good friends from many, many years of working. Ideally, we should all be in some nice lecture room when we can all meet each other and say hello, etc., etc. But current pandemic restrictions obviously mean this is an alternative option. So I'm very, very pleased to be the first speaker in this sort of BASCARD masterclass. And what I'm going to do is get my slides up on the screen. So they should be up. So hopefully you can all see them. So yes, I'm delighted to present this evening. And it is very, very lovely to see so many people and peek into their gardens or their living rooms or their wherever they are. And many, many, many people on the call have worked together for at least the last 20, 30 or 40 years. But what I'm going to do in the next sort of 40 minutes or so is really do a combination of sort of personal reflection and also academic overview of the topic of oral health inequalities. Now, my title has been very carefully chosen title of From Basement Prosthetics Lab to Oral Health Inequalities, Reflections on a 40-Year Journey. And I'll explain more as I go on the significance of my title. So, oops, now why can't I move forward? Is that not moving forward? Let's try again. Here we go, perfect. So the overview of what I'm going to be really doing in the next 40 minutes or so is really review progress collectively on tackling the issue of oral health inequalities, which I think the vast majority of people on this call are familiar with, and it's a point for us to reflect and look backwards and forwards. So I want to look really at the evolution of our understanding on oral health inequalities and really highlight some shifts in policy responses that have taken place across certainly my career to date. And then also, as I said, to reflect on sort of personal career development and choices that I've made and that might be helpful for people who are at the earlier stage of their career. What I do want to say is quite a bit of this presentation is actually taken from a presentation I delivered recently to the GOHERIN, the IEDR Global Oral Health Inequalities Network. That was mostly an international audience, whereas most of the audience tonight are BASCOD members in the UK. So hopefully most of you have not heard most of this content before. But I want to start off my presentation with reflecting a little bit about dental public health as a discipline, as a specialty, and BASCOD as our professional organisation, certainly in the UK. Now, if I was doing this in the sort of real world, I would be trying to interact with you all. But some of you might wonder, what on earth is this picture showing of this woman in a red outfit? Well, this woman is Edwina Currie. Now, she is a British politician. She's a bit of a comedian now. She's been on stupid television programs and is almost like a pundit that is called up to make comment. But back in 1986, she was in the Conservative government at that time, and she came to the BASCOD meeting in 1986, which was my first meeting of BASCOD, and I can vividly remember Edwina Currie. She was wearing a red dress, not this outfit, but a red dress, and she was a really startling political figure, but also a very charismatic politician. And the point I'm making here is that that was my first experience of BASCOD, and I will never forget it, because it was in the Royal Society of Medicine in London. It was a prestigious institution. There was a leading politician of the day speaking at our event, and it was a very exciting place to be at BASCOD, and that was my first meeting. And I suppose the point of reflecting on that is I feel a real sense of pride in our discipline. And I think, quite often, many of us tend to be quite hard on ourselves. And I think at times we should be actually very proud of our achievements. And I think as a small discipline, both within the UK and internationally, we have done actually incredibly well over the years. If you think our discipline of dental public health has had a significant impact on dental policy, oral health policy, on the training and education of the oral health workforce, and the academics amongst our discipline have had a huge impact in terms of the research activities. I think I would struggle to think of another dental discipline, specialty, that has had such an effect on policy, education and research. I also think, and I am a bit of an optimist, I think in the current climate, we have got far greater professional recognition than ever amongst our professional colleagues, both within dentistry, but more broadly across the health and the care sector. And I would argue that dental public health is more important than ever, so that we should have a very sort of optimistic future ahead, that dental public health really has an important role to play. So that's my sort of opening gambit, that we have done a great job, we should be proud of our achievements, and I think we should develop and move forward in terms of our roles. Now, this next slide is a bit of a historical sort of image, and this is taken from a recent exhibition a couple of years ago at the Wellcome Trust in central London. And this is an etching from 1787, beg your pardon, from Paris. And this is an image of healthy teeth being extracted from street poor children in Paris. And those teeth were used then to create dentures for wealthy Parisians. So that, in essence, is about inequalities across generations, across socioeconomic status. I think things have improved since 1787 in that sense. We're not quite as dramatic in terms of inequalities, but inequalities in oral health has a long history, and let's look at that history now. And I would like to sort of look at the history of oral health inequalities from a personal perspective, and this is my sort of personal timeline, because I started dentistry, hard for me to believe, but back in 1979, which I know is like a different generation for many of the younger people on the call. And so what I want to do is basically reflect on my student days as an undergraduate. I want to reflect on my relatively brief but NHS career as a community dentist, which I'm very, very proud of. I then want to go through what I'm slightly tongue-in-cheek calling the wilderness years, when I did my master's, PhD, and a sort of apprenticeship in academic dental public health. And then I want to end with what I'm calling the sort of golden years of where we are now, when so much is happening that I think is positive, exciting, and provides a lot of opportunity across dental public health and beyond. So let me start at the beginning. So I attended Edinburgh Dental School from 1979 to 1984, and that's only 5 years. And I think for the vast majority of us on this call, most of us whom are dentists, it's quite interesting to reflect that 5 years is a very short period of time in our lives, but it's such an important element in your life, that undergraduate experience. And looking back at dental school, I didn't really fit in. I didn't really enjoy dental school. It really wasn't my best time and place for me personally. However, I did, I think, start developing my sort of political and social values were developed at that time. I was very clear that a sort of specialist career in clinical dentistry really wasn't my particular preference. And my reference to the prosthetics lab is, and I don't know if anybody on the call is an ex-graduate of Edinburgh Dental School. Liz Kay was, but I don't think she's on the call. But those of us who trained in Edinburgh, we had this horrendous experience in year 3 of almost spending a whole year in a basement underground doing prosthetics, wax-ups of full dentures in this incredibly hot, humid, horrible place. And when I was there, I thought, this really can't be what university life is about. Sitting in a laboratory with wax knives, trying to create whatever we were creating, and I was hopeless at it. But that dread of prosthetics has sort of remained in me for many, many years. But what I did do in Edinburgh, and again, some of you will know the names, but Professor Andy Blinkhorn, Professor Lona Skoo, they both taught me in Edinburgh, and that was my initial interest in prevention and in behavioural sciences. We didn't call it dental public health, we called it community dentistry or prevention, really. And also a real interest of community in terms of my focus as a clinician at that point was my particular major interest. So from Edinburgh, what I then did was move into my first clinical job. I wasn't the type of person like some of you in the call possibly that did a house job and did, you know, a lot of time in dental school. I really wanted to get out of the dental school as soon as I possibly could. And I was exceptionally lucky to have my first job in the northwest of England. And I know someone on the call is Eric Rooney, and Eric and me both did our vocational training in the Mersey region as it was then. And I had a real interest in developing my clinical skills in special care dentistry. I don't think we called it special care dentistry at that time, but I can remember, and maybe this is getting too personal, but I remember treating patients in what was called Greaves Hall Hospital, which was a psychiatric hospital outside of Southport, north of Liverpool. And that hospital, which probably now is luxury flats that's probably been sold to a developer, but at the time it was a psychiatric hospital where there were people that had major disabilities, and we provided the dental care to that community. And it was a really incredible experience at the beginning of my career. And the person I worked for was somebody called Dr. Hilary Hodge. Now, some of you might know that name, but Hilary Hodge was a real sort of tour de force. She was a very charismatic, very powerful woman that led a very successful salary dental services. And she also had a very successful dental health education unit in South Sefton, as it was called then, and that's something I sort of gravitated towards. So my interest in special care dentistry and dental health education was formed in that clinical experience in the early 1980s. However, at that time, the UK was going through a very traumatized political period, and Margaret Thatcher was in prominence in terms of politician. And I think my interest in public health really was sort of stimulated at that early stage, working in Liverpool with Hilary Hodge. Now, unbeknown to me, I was working in schools, delivering health education, believing I was making a major contribution to oral health in the community. I really strongly believe that. But I had no notion about inequalities really at that time. But at or around this time, Lona School in Edinburgh published a study, which is a slide I frequently use, because it just demonstrates a very important point. And in this slide, if we just look at it, there's two outcomes: 0 plaques, so clean mouths and no bleeding. So these are positive health outcomes. And if we look at the results of the school intervention, and we separate the schools into non-deprived, so affluent schools versus deprived schools, if we look at both outcomes, what we can see is before the intervention, there were differences between both outcomes before the intervention, but the differences were not massive, but there was differences. What's important to note was after the intervention, the differences widened. So the inequalities, in this case to do with periodontal outcomes, increased as a result of the intervention, particularly because the non-deprived affluent schools benefited the greatest from the intervention. I was unaware of that, but I probably was contributing at that time to increasing inequalities in my population in North Sefton. And this slide is just a very much more recent example of exactly the same effect. So this is from our journal, Community Dental Health, 2018, results from a German study that demonstrated exactly the same effect. that a school-based oral health education intervention that was not targeted in relation to deprivation, rather than decreasing, actually increased inequalities, in this case to do with dental caries. So this notion, something I was completely oblivious to, but subsequently are aware of, is this notion of what we can call the inverse prevention law. I think most of us on the call will be familiar with the inverse care law in relation to the inverse relationship between provision and use of services in relation to need. Well, the inverse prevention law is one which states that when interventions may be successful at improving health outcomes across a population, however, what they may also do is increase inequalities within that population. So that's something I think we need to bear in mind as a specialty group. Are we improving or decreasing health inequalities? But in the 1980s, there was, for the first time in the UK certainly, there was a report published called the Black Report. So this rather scrubby looking document was the Black Report, and that was published in 1980. But that report was published, it was commissioned originally by a Labour government, but then a Tory government came in, and when this document was published, the Tory government of the time tried to suppress its population, because this Black Report was the first analysis that showed socioeconomic inequalities in health within the UK, and really began the sort of journey of health inequalities as a both public health and policy priority. The image is here of Margaret Whitehead, and certainly those of you that are working in Liverpool will know Margaret very, very well. And Margaret was a real pioneer in terms of her role, I think, within the Health Education Authority at the time, for really helping to get the Black Report fully published in a later document with what was also called the Health Divide. So a really important pioneer, Margaret, in terms of moving the inequality agenda forward. So that was really my NHS time in both Liverpool, and actually I also worked in East Anglia for a few years. But that was my grounding in dental public health. And I have to say, I'm exceptionally pleased that I did have experience of working in what was then called community dental services. I think that really helped shape my understanding of public health, my understanding of health needs, my understanding of inequalities. I think if I'd been someone who had stayed within a dental hospital environment, I wouldn't have had that exposure to the broader community. So I was really, I think that's a major benefit of my early career. However, from actually 1988, but from the sort of late 80s, early 90s, I then moved to London, and this is an image from UCL in the centre of London. I haven't been to UCL for months and months and months because of the pandemic restrictions, but UCL is one of the universities in London that is a major academic centre for public health. And I'm calling it the wilderness years because in this period between 1990 to 2010, more broadly, there was not such a focus on health inequalities, but within the UCL community, there most certainly was. And there were particularly two individuals that were really instrumental for me in improving my knowledge, understanding around the issue of inequalities in health and inequalities in oral health. Now, many of you on the call will be familiar with both of these images, but one is Professor Aubrey Shyam and the other one is Professor Sir Michael Marmot. Both incredibly important figures in my career, and I think also very important figures globally in terms of research, policy, advocacy on health inequalities. And those of us who were particularly privileged to be taught by Aubrey. I think we'll never forget his contribution to us individually and collectively in moving the agenda forwards. And I know on the call, I can see, for example, Shlomo is on the call from Israel. He was somebody that benefited from Aubrey's wisdom and charisma early on in his career also. But what I did was, during this initial period, I did a master's and then a PhD at UCL, and it was an incredibly exciting environment to be a sort of junior academic. But at the early point of my sort of academic career, my main interest was actually in health promotion. I was most interested in the implementation of health promotion and very heavily influenced by the WHO Ottawa Charter that had been published in 1986, just a few years before that time. Some of us, Sabrina Fuller, myself, Blaney Daly, we formed what was called the Oral Health Promotion Research Group at this time, and that was really about trying to bring together academics to improve the quality of evaluation of oral health promotion interventions. I can remember the exciting, scary first meeting we had at the British Dental Association when we had some sort of high-profile speakers, including Jill Bradnock and Lorna Skoo. We had some excellent speakers. I then became involved in the Health Education Authority. Some of you remember Health Development Agency, it became known as, and began to get involved in national programs around oral health improvement with someone called Kathy Stillman-Lowe, who's somebody that was a really strong advocate for oral health within the HEA. At this time, Aubrey and myself published the first paper on the common risk factor approach, which is a paper that is now cited many, many times, and I will explain a little bit more about in a moment. And we also had a very strong interest at UCL on sugar as a public health priority. Now, in the early 90s, sugar was really very much a minority interest. It wasn't like now when it was recognised as a public health priority. At that time, it was very much a minority interest. But what was also important is that in terms of inequalities, the Aitchison report was then published in the late 1990s, and oral health featured within that Aitchison review. Because Aubrey and myself submitted evidence to the Aitchison report on oral health inequalities, and I recently spoke to Michael Marmot about this, because he was a member of the Aitchison report, and what he said to me directly was he remembered well, Aubrey came to the Aitchison committee and presented the data on oral health. It was among the clearest, most stark evidence of health inequalities that the committee reviewed. So I thought that's a really interesting and sort of powerful message that our oral health data, even back at the Aitchison review back in the late 1990s, had an influence and was recognised as being an important part of the inequalities story. This is just the image of the common risk factor. Again, I think everybody on this call will be familiar with the common risk factor. But I think an important element that we need to recognise is, although now cited, I think I've lost count of the number of times the paper is cited, but it's been a highly influential paper about bridging the gap between oral diseases and other chronic conditions, giving the opportunity for us as a community to link across that broader public health agenda. And I think it's been a very successful tool to help people really sort of move forward in that broader agenda. What we also did at UCL in the early 2000s was really begin to highlight the need for a more complementary range, a basket of interventions to tackle health inequalities. So it wasn't new, it dated back many years beforehand, but the idea of the upstream, downstream analogy, and Aubrey used to present the slides on this so brilliantly, but we recognise the importance of downstream prevention, but we also recognised and highlighted without midstream and upstream interventions, inequalities in oral health were not going to be tackled. So thinking about the downstream prevention, I think a very important development around that time, Sue Gregory, many of us will remember Sue Gregory as the director of dental public health, first director of dental public health at Public Health England. She led the first edition of Delivering Better Oral Health to improve the evidence base of clinical prevention. I was very pleased and proud to be part of that initial group, and Jenny Godson and colleagues have done a great job in moving forward with Delivering Better Oral Health. So we know the importance of clinical prevention, we know the importance of evidence base to inform clinical prevention, but we also know the importance of midstream interventions. So some examples of that, some of our students from Thailand, from Brazil, other countries, looked at the evaluation of healthy school programs, looking at the total school environment, improving the opportunities for health and oral health, and evaluating the value of these interventions. And increasingly now, this issue of a place-based approach to prevention really is about a sort of midstream agenda. And then lastly, I think again, most of us on this call will recognise the absolute importance of upstream healthy public policies. And WHO and other organisations now, perfect example of this is the taxation on sugar sweetened beverages and other examples we can give. But the upstream agenda, I think, we advocated for that. We've been doing that for many years. And I think now the traction and movement on that is really beginning to happen. So I'd like to then begin to move towards the end and sort of think about what we could call the golden years. And that's really the last sort of 10, 15 years of the inequalities agenda. And if, as like me, you were very privileged and lucky to be at UCL, Michael Marmot in particular, if we look at this sort of broader public health agenda, he was very influential in publishing the WHO document in 2008 on social determinants of inequalities, the UK Marmot Review in 2010. So the focus increasingly on social inequalities and the social gradient really became much more centred in terms of policy discourse, both in the UK and internationally. I think also a very important and very positive development was the conceptual frameworks that were developed to explain the processes and pathways for health inequalities, and the increasing accumulation of evidence on health inequalities in terms of evidence base and on sort of policy developments. So a real sense of movement, a real sense of the time and place was right to move forward with the health inequalities agenda. And these are obviously the examples of the WHO and the original UK or English review of health inequalities. This is the theoretical framework, the sort of basic tuned down version of the theoretical framework that was in the WHO inequality document. And I think this is incredibly important to inform interventions, that we need to understand the range of distal, proximal influences on patterns of disease and most certainly patterns of inequalities. And I think a very important message that Marmot and others have highlighted is that healthcare systems are an important element of that determinants. Health behaviour is an important element, but there are many more further upstream factors that really drive the social patterning of health inequalities. So in terms of policy development, in the last 10, 15 years, the really broad recognition now is that to reduce health inequalities, we need a multifaceted approach, strengthening individuals, health literacy, development at an individual and clinical level, very important. However, we also need to strengthen communities. So that's looking at some community approaches, community development, place-based action, improving infrastructure, access to essential services, and then very, very importantly, action on structural changes to economic, cultural, environmental conditions. That whole agenda really has moved forwards in such a significant way in the last 15 years or so. Reflecting on oral health, I also feel very positive. I think the research base on global oral health inequalities really has expanded significantly in the last 10 to 15 years. We have significant levels of detailed evidence on gradients in a range of oral health outcomes in different countries, different points in the life course. Many of us dental public health researchers around the world, including colleagues on the call here, have done advanced analysis on determinants and pathways on oral health inequalities. Different policy initiatives have moved forward. For example, the International Centre for Oral Health Inequalities Research and Policy, which has been a really successful marriage, really, between academia across the UK and internationally and policymakers. And it's been absolutely great to have Sandra, Jenny and other members from Public Health England actively involved in that group. More broadly, International Association of Dental Research established the Coherent Groups. That's a global oral health inequalities network. Public Health England have done a lot, and we'll show more in the details in a minute. FDI, BDA, WHO, I think a whole range of our professional global organisations are now focusing on oral health inequalities in different ways in a creative manner. And that last bullet point about the canary in the coal mine, when Aubrey was alive, I remember Aubrey, myself and David Williams meeting about this notion of the canary in the coal mine, how oral health is such an accurate early indicator of health inequalities more generally, and can be used as a barometer for wider public health in terms of patterns of inequalities. And again, we've moved forward with that agenda. I suppose a couple of slides just to show you some examples of this work, and this is a paper by Eduardo and Aubrey looking at the inequalities, the social gradients in levels of edentulous across social classes from the different waves of the UK, England and Wales and Scotland surveys. I know the population samples are slightly different, but this image of this consistent social gradient across our social hierarchy in our population is a very powerful message. And again, there's a slight aside, but Michael Marmot is speaking in a few weeks' time at a conference, I think up in Yorkshire, on oral health. And he asked me to give him some slides on oral health inequalities. And he just emailed back to me and said yesterday, it's incredible how stark and evident the social gradients in oral health are. And I think we forget that. The levels of edentulous have declined overall, but the social gradient has not changed. That inequality has remained. For me personally, a very important development 2 years ago was the Lancet series on oral health that was published. So we had 2 papers in the Lancet, and I have to say, for me personally, I think it's without question this is probably my sort of proudest moment as a sort of dental public health academic. If I'd thought back in that prosthetics lab in the basement in Edinburgh in 1981 whatever it was, that I would be publishing the Lancet. I would have thought that was crazy. But the point is, oral health, the agenda of oral health has now broadened, and journals like the Lancet have now recognised the public health importance of oral health. And in those papers, one quite exciting thing I think we did was really expand and broaden the determinants of oral health, and including not only the social determinants, the familiar elements we showed you earlier on, but also to embed that with what we call the commercial determinants, which is principally the corporate strategies of the transnational sugar, tobacco and alcohol industries that promote their products, increase their sales, and both within this country, in the UK, but also internationally, and most importantly, probably in terms of low and middle income countries, and their tactics that are detrimental to health and to oral health. Very recently, literally a few weeks ago, and I think we have to thank Sandra White for her incredible leadership to manage to get the Public Health England report on inequalities in oral health published just before Sandra sadly retired. But that document is a hugely useful overview of current inequalities in oral health, in this case in England. And I have to acknowledge all the hard work that Anya, George and my colleagues at UCL have done in terms of doing a lot of that work, as well as the Public Health England colleagues that did a lot of the analysis of the epidemiological data. But just a couple of examples from this, from the PHE report. This is the slope index of inequality in terms of caries at 5-year-olds, 2019, the sort of most recent data. And that social gradient really is a disgrace that in this day and age, we have such a strong social gradient in caries in 5-year-old children. Really is a point of great distress, I think, in terms of what we've managed to not change through all our activities. And another example, which I think is even almost more powerful, this is the slide looking at hospital extraction rates due to caries from 0 to 19-year-old children by deprivation from 2014 up to 2019. And although, again, the rates overall of extractions and base hospital extractions has decreased, the social gradients have not. And if we look at the difference between the least deprived compared to the most deprived, you know, these are children, young children being hospitalized for a preventable condition. You know, it's an absolute disgrace that this is still happening in our country. So looking forward in terms of what's coming ahead. Well, for myself and my team at UCL, what we have got is a very exciting opportunity now to be working with the WHO as a collaborating centre for oral health inequalities. So we're involved in a range of different initiatives at WHO. And again, you know, from BASCOD to WHO, the agendas, often a lot of commonality, a lot of exciting opportunities, both at local, national and international level. And again, as Ross mentioned, another big development, which I think we should as a discipline again acknowledge the importance of, is this Lancet Commission on Oral Health that's been formed. And we've got a group of 25 commissioners from all over the world who are working together on this really important policy research initiative that hopefully will have a real impact globally. To end the presentation and to open up for discussion, I thought a few final slides on sort of future direction of travel based upon what I've been sort of describing in terms of my personal career and the sort of more academic and sort of policy angles. I think I would like to make a real plea for us to begin to move beyond measurement and descriptive epidemiology to actually now moving much more into action, implementation, evaluation. I would make a real plea, it is time for action. I think we've got enough data, we've got enough graphs, we've got enough figures. We need now to move forward, expand our evidence base on interventions that actually change those social gradients that we've been talking about. I think another important message I've sort of picked up in recent years in my career, and it's almost going full circle, is I think public health and social care as a clinical and public health discipline, I think we have a lot to work together on. So in terms of the inequalities and social inclusion agenda, I think socioeconomic inequalities are very important, but so are vulnerable population groups. And I think that combination of a clinical special care dentistry with a population public health focus is a very, very, very important one. So my argument would be it's time for action, it's time for implementation, time for evaluation using appropriate measures and outcomes to improve our evidence base on interventions. I think advocacy is central to that role. And this is where I think BASCOD has a very important role to play. As a professional organisation, I think BASCOD should be leading the way in terms of advocacy around such topics as oral health inequalities. And a very important gap in our professional development really is the lack of community and civil society engagement that we have had. We've tended to speak to each other, we've tended to communicate within our professional groupings. I think we have not been successful enough in moving forward with community and civil society engagement. And that's, for me, a big priority for me moving ahead. So in terms of career insights, the sort of lessons I have learned, I would say the following things come particularly to mind. I really think having a community experience clinically is absolutely essential. I think without my experience of working in Liverpool with Hilary Hodge, working in East Anglia with others, it really grounds you in that reality. So I would strongly recommend that for all of us working in dental public health, that community experience is absolutely essential. I would also argue that as a career sort of move, I think, we learn most from the talented people that are around, and there's many of them. So I would gravitate to the best and the brightest in our community in terms of what you can gain through working with talented, bright and energized colleagues. I think what's absolutely essential and very clear to me is that dentistry is very important, but we need to work in partnership and escape what we could call the silo of working in isolation. Now, I have been exceptionally fortunate to work across many different organizations, many different sectors. If I think my career had been limited just to be within the four walls of a dental surgery, I think I'd have gone completely bonkers. So escaping that silo, I think, is absolutely essential. I think perseverance is really important. Excuse me, that's my dog barking. Perseverance is very important. And I think progress takes time. So those of you at the early stage of your career, you need to give yourself time, and progress will eventually move forward. I think this issue of advocacy, speaking truth to power, challenging the status quo is really, really, really important. Now, I suppose one concern I have is that some elements of our discipline almost become too close to government and are not independent enough to be able to challenge, argue and advocate for change. And this issue of being bold, aspirational and ambitious, I think, is essential. I think if we look for too much of a small change, we're losing the big picture. We are in public health, we are in population health, we look for change on a bold aspirational level. I think we also need to look at this politics of change. Colleagues in the US a few years ago would think, well, what's the possibility of public health in the US? Well, within literally a space of 6 months, opportunities have suddenly radically changed within the, say, US context. Literally before this meeting, I had a meeting with people from Penn State University that are now talking about inequalities as their central focus in terms of research, in terms of training, etc. That window of opportunity has suddenly opened for them. It will open again for us at some point. And I think the sort of final insight from me in terms of career would be also about importance of trusting in others and working in a team, a cohesive, supportive team. And again, I have to say I've been exceptionally lucky to work with such a cohesive and supportive team of people at UCL over many, many years. My last slide would be things to avoid in terms of career and reflection. A particular bugbear for me is arrogance and self-importance. I think we need to be very careful not to come across as being arrogant or too self-important. We also need to be careful not to be superficial in our approach. There are no quick and dirty solutions to complex, wicked problems. We need to do things in depth and detail. Superficiality, I don't think, is appropriate. I think we need to be careful not to disconnect from our communities. Ultimately, in public health, we are serving the public. We are funded through public resources. I think that importance of community needs, being responsive to communities, is absolutely essential. I think another thing we have to be careful to avoid is adopting a sort of atheoretical approach. We need to have theoretical frameworks to guide our practice, whether that's policy practice, clinical practice, research activities. We need a theory base. I think we have to also be careful not to value quantity over quality. I think some academics can be guilty of wanting more and more papers, where really what they ought to be focusing on is high quality outputs. And I think lastly, maybe we need to be careful not to be too narrow and insular in our focus. I think the joy of public health is the breadth and opportunities that lie ahead for us. So that is my presentation, my masterclass, we're calling it. I would love much more to be in the audience to see you all, because I'm sitting in front of my computer. But I think what we're now going to do is we're going to now open up for discussion with the audience. How do I get this out of? How do I?
There's a little box at the top.
That's it. Yeah. Done it. Thank you. So open to discussion, questions, debate.
And I know Alona's we had some questions in advance, and I think Alona might have one to kick us off with.
So thank you so
Yes, thank you.
Professor Watt. It's a great privilege to actually even be here, because obviously, you know, having gone through training, it's one of those things to actually, it's a wonderful thing to actually be able to participate in something where you've got people who you've learned from, you've read their papers, they're speaking to you, and it's a wonderful thing. So thank you. So the first question we've got is, there's quite a lot of people asking about careers. So when in your career did you start to feel that your dental public health messages were starting to be heard?
That's a good question. And just one thing to say, that we're looking forward to the questions. If we don't have the answers, I think what we've agreed is that we will facilitate discussion across BASCOD, and there can be different ways we can address these interesting questions. That's a good question. I think I felt most positive, really, as I tried to explain, in the last sort of 15 years or so, when the mainstream agenda has really focused on inequalities and population health. And I think, many of us on this call, I think we suddenly began to make a difference, and we're listened to more seriously by professional colleagues from many, many different disciplines. So I think the penny for me dropped really about 15 years ago, where suddenly it seemed people were interested in what we had to say. That would be my answer.
This is going to sound a little bit like a job advert for a second. And if anybody wishes to ask questions, you can put your hand up and ask questions yourself. But I'm just going to start with a few questions here while everyone's having a think. Looking back at your early career, which you've spoken about today, what would be the one thing that you would have done differently?
What would I have done differently? That's a very good question. It does feel like an interview, and I'm probably not going to get the job based on my response. I'm not sure I'd done anything different, actually, because I think I do remember I was interviewed for a job in the Wirral, and I didn't get that job, and I was so upset not getting that job. But actually, I think in retrospect, it was much better that I got my job with Hilary Hodge, because I think without Hilary, I would never have ended up at UCL, because she was linked to Aubrey and to Diane Plamping. So I think that probably was a good move. I didn't get my first job, and although I felt very dejected, it probably was a good move.
We've got a few questions about, some people are very interested in dental careers. We've had a few questions on dental careers. And one of the questions is, what advice would you give to someone who's considering pursuing a career in dental public health or dental public health academia?
I think I would encourage you, because I think it's an interesting, rewarding career. And I think, you know, I mean, I don't want to be too, I'm not Mary Poppins, I don't want to make things sound too perfect, because it's not always been great. But I think an academic career in public health, dental public health, gives us the opportunity to make a difference at a population level, to teach, and I've enjoyed teaching immensely over the years, both undergraduate and postgraduate students, and also to be involved in research. And I would say, in terms of the UK in particular, with NIHR, there is a huge range of opportunities for research training, for fellowships, for different grants, for program grants, etc. I think the opportunities are endless. So I would encourage people to explore a career in academic dental public health. And I think to get there, you need to demonstrate a commitment to the topic. So I would try and get experience in different settings, perhaps in community, primary care, hospital. Ideally, try and publish some papers beforehand, because that will help you raise your profile when you apply for posts, etc. So I would encourage ambition in terms of a career in academia.
Now, there's a couple of questions from the floor. Maria, you had a question which you put in the chat, and then I'll go to Anikiri, who's also put his hand up in a moment. So if I go to Maria first.
Oh yes, I did. So Richard, I mean, I think I came away being a bit more optimistic actually than when I wrote my question, and I put, we're rather good at describing inequalities in oral health and wider health. You know, what is the best thing that we aren't currently doing that Bascod could drive forwards or champion to help to tackle inequality? And I think you've alluded to some of it. Call to action, the community, some of those things that perhaps we need to refocus a bit.
Well, I think, my memory of Edwina Curry, and she was a Conservative MP, Conservative minister. She wasn't talking about inequalities, but the point was we were engaging with politicians. As an association, we were engaging with the government at the time. And I think, the world has changed a lot. Different organisations exist. But I just think for Bascod, I think our advocacy role, our independent, critical advocacy role is a very important one. And I know Maria, you've done a great job on revitalising the sugar guideline, which again is a good example. But I think as a professional association, we've got a lot of expertise, we've got a lot of people with a lot of experience. And I think that advocacy, that lobbying role, both professionally and both nationally, locally, internationally, I think there's a real role for Bascod. And I think And we're all very busy people, but I would sort of plea that that's something that we can develop further again.
And the working with partners, which you mentioned as well, and the broad partnerships, you know. So thank you for that. Sorry, Lona.
No, that's fine. If I can go to hoping I pronounced this correctly, Anikuriti Panda, I believe you've got a question.
Hi, Richard. This is Anukriti, and thank you so much for your inspiring presentation. I have a very basic question. So I am a dental graduate from India and I'm registered there. And I am currently doing my master's in public health from the University of Bristol. So if I would like to pursue a career in dental public health, what would be your advice to me? How should I proceed with it?
Well, very good question, and I'm glad you're enjoying your studies in Bristol, and that's a very good place in terms of public health. They've got lots of interesting things happening there. I think, and again, Maria, we talked about this before. I think this issue of career advice is a tricky one because we know within the UK currently, unlike within public health training, to do dental public health training as a specialty, you need to be a dentist on the GDC register, which clearly at the moment excludes people from overseas that are not in that position. Now, I think, you know, we've had students ourselves at UCL who are in a similar situation to yourself. There are other opportunities in terms of public health career opportunities. I think there are more of those beginning to open up within the NHS as well. And as Ross mentioned at the beginning, I work in a community and mental health trust, and we currently are trying to create a public health role within a community trust where at the moment there's no public health at all. So I think, I can't answer all the question now, but I think it would be good to continue that discussion with our BASCOD colleagues, and I would think more broadly rather than only for dental public health, because at the moment that opportunity isn't open to non-UK graduates, dental graduates.
Right. Thank you so much. Thank you so much.
I think as a society we could have a section perhaps on the website with some useful links, because public health is quite broad. So for example, the UK PHR, the Public Health Register, and practitioner roles as well as specialists and consultants. So perhaps we could beef up that section on our website and guide people there. So thanks very much for your question.
We have a further question from the floor from Janine, if you're happy to speak.
Hi, hello, Professor Watt. Thank you very much for that talk, and also thank you very much for being my PhD supervisor. It's been a brilliant few years, and I'm incredibly grateful to have had the opportunity to work with you. I wanted to ask a question about translating research into policy and practice, and what you've learned across your career about how we can make that leap from what we're doing at the universities to getting that recognised really outside of those institutes. Thank you.
Thank you, Janine. Good to see you. I think very good question, and I think in my career, almost from very early days, I managed to get involved with people as the Health Education Authority, and those organisations as of old, but now there's more recent ones such as Public Health England, Public Health Wales, and other. I think those organisations do need academic input, and I think you know, I know we've got a lot of Public Health England people on the call. I think there's now a much broader partnership between people working policy, either at local or national level, and academia, and I suppose that's one sort of broader issue that I think is a real strength of BASCOD, is that we've got our academic arm, we've got our policy arm, we've got our clinical arm, and together it's a very important partnership to guide things together. No other specialty really has that, and I'm very confident that Anna Ireland and colleagues in Public Health England really want to work with academics in different ways. And I think that is happening much more than ever before. So I think, Janine, in your career, that's something that I think really will happen. Absolutely.
So
Thank you.
Thank you, Janine. And so we're going to ask one more question, if that's all right. And then with the remaining questions, I've just spoken to Maria briefly to say that what we'll do is we'll give you those questions so that we can put an answers together for the questions that have been asked, which can go to the members, or with the YouTube video, we can pop something into as a document. So the final question is, what do you think is the balance now needed between the upstream, midstream and downstream policies in oral health inequalities?
Very good final question, a big question. I think one thing I would probably argue is that a lot of people now talk about social determinants. A lot of people now talk about upstream interventions, but there's a term what we call lifestyle drift, and it's Jenny Popes, as a sociologist in University of Lancaster, coined this expression that people sometimes now adopt the language, but ultimately in the end what they do is go back to conventional traditional practice. So I think, you know, I have been harping on incessantly for the last 20 years about upstream interventions, and I'll probably continue to do so until I finish. And I think what we need is that combination of across upstream, midstream and downstream. As a profession, not only the dental profession, but health profession more generally, there's a very strong tendency to keep downstream only. Upstream is more difficult, more challenging, more time consuming, more complex. Therefore, I think we need to keep the momentum going for that combination across. And I think maybe the final point I want to say, I suppose, is, and I can see that Lorna McPherson and others are on the call, we now also know the need to improve the evidence base for upstream interventions. So Lorna, myself and Blanna Daly and some others are working on a review of upstream interventions to really consolidate the evidence base for that approach. So a bit of a waffled answer, but I think we need altogether, we need a combination and be vigilant about that combination.
There's a couple of things in the chat as well, but we'll add those questions if that's all right. In the interest of time, we'll give you those questions, and I hope that's helpful. So I'm going to stop the questions now because we're running a few minutes over, and say thank you so much for, from a personal perspective, I'm sure from everybody else, that say thank you so much for answering questions and for a wonderful talk.
Thank you.
Maria?
I'm muted. Very sorry. Thanks very much, Richard. That was really, well, a call to action and great reflection on your career as well. And thanks for suggesting the idea of the masterclasses in the first place. So I'd like to hand over to Ross, who's just going to close the session for us. Thank
you very much. So yeah, I'd just like to say, firstly, thank you very much, Richard, for coming today, presenting for us. It's been a really interesting talk. I think everyone agrees that it's been very insightful. I'd like to thank Lorna for coming and helping with the panel today, and of course thank you to Maria for making all this happen. I think it's been a real success. At the peak we had 104 people online, so I think it's been absolutely excellent. I'm just going to share.
Thank you to you, Ross. I'm terribly sorry for missing out, for organising the whole event for us. So thanks very much.
Thank you very much. I'm just going to share a couple of slides very quickly. Obviously, we've offered this session to everybody with or without a BASCOD membership. We want to continue offering these masterclass sessions in the future. And if you'd like to be able to attend those, I think that it's likely that they may only be available to those who are members of BASCOD. So if you are interested in joining up, if you have an interest in making an impact on population oral health, and you've been inspired by what Professor Watt has said today, then I'd really recommend that you join the society. The QR code there on the screen, if you we're all quite used to using QR codes now during COVID, so if you want to just point your phone at that, that'll take you to the BASCOD sign up, and we'd love to have you. The second thing just to comment on is that we are running a series of these masterclass sessions. The next one is by Dr. Colwyn Jones and is relating to the Child Smile scheme which ran in Scotland. So again, if you're interested in attending this, there's a QR code on this screen here, which you can scan. We're also going to be sending out information through the usual channels, social media, and on the BASCOD website. So if you're interested in signing up for that, then we'd be very happy to have you at the next masterclass session as well. So that's everything I have to say. I'm going to bring this meeting to a close. Thank you very much, everybody, for coming, and we'll hopefully see you in a couple of weeks for Colwyn's presentation.
Bye.